Hello, my name is Yvette Sejas, and welcome to our second keynote talk for the day, Understanding and Addressing Disparities in Pediatric Healthcare. We're delighted that you guys are with us here today. Before we begin, I got to stick with those few announcements for those of you who maybe are popping on for the first time. Oral translation is available in English and Spanish. To access oral translation, go to the bottom right of your video player to find the headphone icon. Click on the icon to choose English or Spanish. A few little changes for the captioning. Captioning is still available in English, Spanish, Japanese, and Portuguese, but we want you now to go ahead and just click on the tab next to the chat or the Q&A tab. Please go ahead and still use that chat function to tell us, where you're from, connect with your other fellow attendees, or just post comments throughout the sessions, or if you have a question for myself as the moderator. With me today is our language facilitator, Lorena Enrich, and she is here to translate questions or comments you pose from Spanish to English or English to Spanish. If you have any questions for the presenter, please post them using the Q&A tab located in the upper right-hand corner of the screen. Finally, if you wish to receive credit for professional and continuing education for the session, you're required to complete the quick session feedback and CEU learning assessment form at the end of the session. As a reminder, you must be here throughout the entire session in order to get credit, and make sure you complete that in order for you to obtain those. And now I would like to introduce our presenter, Dr. Dylan Chan. He is a professor from the Pediatric Otolaryngology Head and Neck Surgery at the University of California, San Francisco. He is the founder and director of the UCSF Children's Communication Center, which is dedicated to multidisciplinary clinical care, translational research, and pediatric hearing health disparities, and community outreach and education. So I'm super excited to go ahead and pass the mic to Dr. Chan. Take it away.
Awesome. Thank you so much, Yvette. It's really, truly an honor and a privilege to be here speaking with AG Bell. Thank you to Hartley and Gayla and the whole team for this opportunity. So yeah, I'll be talking to you about disparities in pediatric hearing care, specifically along a translational health equity approach, and I'll explain what I mean by that. So I'd first like to just acknowledge all of the members of my wonderful team here at UCSF that I have the privilege to work with across audiology and speech and education and social work. A number of the students and trainees that have done some of the work that I'll be presenting here today are listed here. And this work has been supported by the Patient-Centered Outcomes Research Institute and the NIH. So this is Isam Dam. He was on the cover of the New York Times last year, and it is extremely exciting when anything relating to hearing appears on the cover of the New York Times. But he was on the cover of the New York Times as the first person in the United States to receive gene therapy for congenital deafness. And I'm sure many of you heard his story, know about efforts with gene therapy, and that we now are able to do gene therapy for congenital deafness. And this was hailed, rightly so, at the time as a triumph of medicine. It illustrated how translational research, right, that is learning about the basic mechanisms of human disease to design specific interventions to treat them, can be used to restore hearing. And this was a truly international effort. Scientists in France discovered the gene otoferlin, which causes auditory neuropathy. Colleagues of mine here at UCSF, as well as scientists in Germany, figured out how to use gene therapy to restore hearing in mice. And Isam was identified, he's from Morocco, he was identified in Spain and brought over to the United States for this gene therapy. And so you might be wondering what all this has to do with disparities in pediatric hearing healthcare, right? Why am I talking about gene therapy? And after all, the perception is often that disparities are important to know about, but what can we really do about it, right? We know that deaf and hard of hearing children of families that are lower income or with less education or live in more rural areas have worse outcomes. But what can we do about that? Well, today I'd like to talk to you about how we can use this exact same model of translational research to understand how we can better support all children with hearing loss. But instead of discovering genes and designing gene therapy, we'll be talking about understanding families and families' needs and how to design interventions to support them. And I hope that at the end of the talk, that you'll recognize that even though you might not be able to develop a virus to perform gene therapy, that every one of you in the audience today can have a direct impact on translational research and to address disparities in pediatric hearing healthcare. So, what is translational research, right? Fundamentally, translational research is taking a clinical insight, right? Identifying an impactful clinical problem, using science to understand the mechanism that is causing that problem, and then to design a specific and effective intervention to target that mechanism to help address that problem. And this can is most traditionally thought of in cellular and molecular terms, right? Developing a gene therapy to fix a genetic problem or developing a drug to treat a cancer. But you can apply this to any other level of human conditions. It can be physiologic or anatomic, neurologic or behavioral, or it can even be applied to sociodemographic and health systems levels. So in the space of hearing healthcare disparities or hearing healthcare for children, let's start with the clinical problem. And all of you know about this, right? In the United States, this is from CDC data from Universal Newborn Hearing Screening. There are over 6,000 babies born every year who are deaf and hard of hearing. And we have a system of care that does perform universal newborn hearing screening, ideally by 1 month of age, so that identification of hearing loss can occur by 3 months of age, so that intervention can be put in place by 6 months of age. And this is that 6 month target is important, right? Because intervention after 6 months is associated with permanent language delays. And that's the fundamental problem here, right? Is that deaf and hard of hearing children are at significant risk for language delays. And that's why we're all here. And we know that the outcomes, the language outcomes for these children are highly, highly variable. We know that this has an enormous impact, right? So the societal economic costs for a deaf and hard of hearing child without early detection intervention is enormous, right? $400,000 a year in direct educational costs, or $1 million in total lifetime costs relating to educational costs as well as lost productivity. So the estimated lifetime costs for all deaf and hard of hearing children in a 1 year birth cohort in the United States is approximately $10 billion. And this is comparable to the lifetime costs for a 1 year cohort of children born with asthma, right? So this is one of the most important things that we deal with as a society. And because of this, in the United States and in many other countries around the world, there are extensive systems of care intended to address this problem, right? There's federal legislation, there's federal law, there are national bodies that all work together to try to optimize language development in deaf and hard of hearing children in these early years. And so like I said, I don't need to convince all of you in the audience that trying to optimize language development in deaf and hard of hearing children is a huge need. What I'm going to spend most of the time talking in this talk is on these next two steps, right? And this first one is scientific discovery, right? What is the mechanism? Why do deaf and hard of hearing children have such widely different outcomes in their language? And we don't know many of these things, right? We don't know what are the factors that cause a deaf and hard of hearing child to have differences in their hearing health outcomes, right? Everything from auditory function up through speech and language and overall development. Most research, most clinical research, as is typical, focuses on clinical factors, right? Things like hearing level, right? Children who are, born severely or profoundly deaf have, greater risk for speech and language delays. Children who have additional medical comorbidities have, additional risks as well. And again, most of the translational research has focused on direct clinical interventions, right? We know a lot about how hearing aids and cochlear implants and speech language therapy and educational services can help mitigate some of these risks, and how well-fit hearing aids worn, all waking hours can improve the speech and language development of children who are deaf and hard of hearing. And we can even quantify how much of an effect some of these things have. So this is a bit of a complicated graph, but this is meant to sort of illustrate the effect. So this is effect size here, the effect of different factors in long-term speech or language development. All right. So I'm an otolaryngologist. I perform cochlear implantation, and cochlear implant surgeons obsess a lot about exactly what kind of electrode we use, how we insert the electrode into the cochlea, and we think that we have some impact there. Right? And these are some of the best studies that have looked at speech perception scores in adults receiving cochlear implants. And looking at the things that we spend a lot of time thinking about, right? What kind of electrode to use, whether we even insert it into the right part of the cochlea, how far the cochlear implant electrode is from the hearing nerve. And these things have, medium effects on the speech perception scores. Some of them have, fairly large effects, all right? But when we actually look at language development in children, other factors come into play a lot more. All right. So this is from the CDACI study, this sort of landmark studies in cochlear implantation that showed that maternal sensitivity and cognitive stimulation, right? These are things that parents are able to do to support their children, have large effects on language outcomes in children receiving cochlear implantation. And one of the things that we focus on most right now is implant age, right? The difference between implanting a child, a deaf child, at 6 months versus 12 months has a large effect on language outcomes. And this is from the Lochi study from Australia. Again, one of the most important and seminal studies in language outcomes in deaf children. So, these clinical factors and our interventions do have large effects on language outcomes in these children. And that's, obviously what we've spent a lot of our research and time thinking about. And when we looked at this data ourselves, so this is our own data from UCSF, we found, that deaf babies, so these are babies with congenital bilateral severe to profound sensory neural hearing loss and no additional developmental delays. If they're implanted in the first couple of years, their language outcomes are within the normal range by and large. And this is a tremendous achievement, right? We have the technology and the ability to provide access to sound and potential for normal spoken language development for deaf children with these interventions. And we found what others found, right? That if children are implanted early, right, before 12 months, their language scores are stone cold normal, right? They are indistinguishable from typically hearing kids. But when they're implanted late, after 12 months, their language scores are lower. But when we dug a little deeper into this data, we found, that while language outcomes certainly correlated with age of implantation, right, that another factor was equally, if not more important. And so what we used in this case was something called the Social Vulnerability Index. And this is a measure compiled by the CDC here in the United States that takes into account a number of different sociodemographic factors and calculates a vulnerability score that is associated with where people live. And this is to a very fine level of resolution, right? And when we used this social vulnerability index, we found that there was also a very strong correlation between social vulnerability index with higher social vulnerability associated with worse language scores. And in fact, when we calculated the effect size, right, the effect of social vulnerability on language outcomes was greater than the effect of cochlear implant age on language outcomes. And so when you put social vulnerability on this same graph, you find that it has a very large effect, and that the effect of social vulnerability is actually greater than any of these other clinical factors that we've come to know and care about so much. So it's necessary then to add to this model of the attributes of deaf and hard of hearing children that lead to their outcomes, demographic factors. Sociodemographic factors affect hearing health outcomes as much as, or maybe even more than, the clinical and interventional factors that we focus on so much. And what are these sociodemographic factors, right? We often talk about or think about social determinants of health, and we think about these specific attributes, right? Things like income, education, racial ethnic background, where people live, what languages they speak at home, and what kinds of insurance they have. And so our work in our group and many others have focused on understanding not just which of these factors are associated with hearing health outcomes, because basically if you look hard enough, all of these are associated with differences. We'd like to identify which are the most important and significantly modifiable sociodemographic factors that impact language development in deaf and hard of hearing children, right? So not just showing associations, but figuring out which of these is most important, which are the actual root causes of these differences in outcomes. So as an example, we looked at insurance type, all right? And so we took a cohort of 80 children who underwent cochlear implantation before 4 years, who had congenital sensorineural hearing loss. And unsurprisingly, right, and we looked at their language outcomes later on in childhood. And unsurprisingly, we found that publicly insured kids compared to privately insured kids had significantly worse language outcomes, right? The privately insured kids had language outcomes that on average were, roughly in the normal range, but those who were publicly insured had much worse language. Similarly, those who, and this is similar to the data I showed before, children that were implanted before 12 months of age had significantly better language outcomes than those that were implanted after 12 months of age. Now, the standard expectation or the standard thinking here is that, well, publicly insured kids have, you know, they have a slower process of getting cochlear implants, right? And so, of course, children who are publicly insured probably have poor outcomes because they're getting the CIs later, right? They're delayed in getting their CI because they have poor insurance, and therefore, because they have later CI, then they have worse outcomes. Well, we looked at this a little bit more closely and did something called a mediation analysis. All right. So what a mediation analysis does is it asks the question, is the relationship between insurance type and language a direct association, or is it an association that is mediated through age at first cochlear implantation? All right. So it allows us to say, is the reason why publicly insured kids having worse language um, because they're being implanted later, all right? Or at least it gets us at that question. And what we found was very surprising, that actually the effect of insurance type on language was not mediated through age at cochlear implantation, but instead it was a direct effect of people being publicly insured. So it's not just because the publicly insured kids were getting implanted later. It was something else about this population. And this is actually similar to what I had showed you before with the social vulnerability index. And so what are the other access barriers that these publicly insured families have? If it's not just, you know, delays in their cochlear implantation. Well, how about home language, right? So we're in California. Many of our publicly insured families don't speak English at home, right? Um, and it's well known and been well described that patients and families that speak a language other than English at home have significant delays in their medical care across the board. This is work that was done by Katrine Gerada. She was a medical student here at UCSF. And she looked not just at children who received cochlear implants, but a large cohort of over 500 deaf and hard of hearing children. And she was interested in these EDI pathways, right? In when children were identified with hearing loss and when they received intervention. And she was particularly interested in home language and birth country, which I'll get into a little bit later. So what she found initially, which was not surprising, is that children who came from English-speaking families had an average age of identification of 39 months and a time period between diagnosis and intervention of 25 months on average. Whereas those who spoke a language other than English at home had a later age of diagnosis and a longer period between diagnosis and intervention. These were not just congenitally deaf children, but deaf and hard of hearing children that were identified at any point during childhood. Now, Katrine was very interested in immigrant and refugee health, and so she wanted to dig a little bit deeper into this and separated out the non-English speaking families into those whose children were born in the United States and those whose children were born outside of the United States. And what she found was that US-born children of parents who did not speak English at home actually had very comparable times to identification and intervention to those families that spoke English at home. And in fact, it was the foreign-born children who had the huge delays in identification, as well as significant delays in the time between identification and intervention. And there are a number of reasons for this, right? The most obvious reason is that many countries outside the United States do not have universal newborn hearing screening. And so there were a number of children who may have had congenital or early onset hearing loss that simply weren't identified through newborn hearing screening outside of the United States. But also within the United States, we do not have a robust system of postnatal hearing screening. And this combination resulted in significantly delayed identification of hearing loss for children who were born outside the United States. So that would explain this big difference of 77 months compared to the 30 months for the other groups. But that doesn't explain this significantly delayed time from diagnosis to intervention, right? Because these children were identified here in the United States, but they had a significantly longer time getting their intervention in place. And so to learn more about that, Katrine went and she interviewed a lot of families. Um, and she did a qualitative study. She recruited 12 families that were Arabic, Chinese, and Spanish speaking. And she employed something called a human-centered design approach to try to understand or to gain insights from these families about why or how they experienced the healthcare system to try to generate specific interventions to address them. And what she found across the board, and this was for the Arabic, Chinese, and Spanish speaking families that were from all different parts of the world, is that all of these families had difficulty navigating and accessing hearing specific healthcare systems. Um, and again, this is not a surprise, but it was because of unfamiliarity with how healthcare works in the United States, or not knowing that their child's hearing care involves both the medical system as well as the educational system, all sorts of things related to that. And but this is a difficult thing to measure, right? This is a difficult thing to know how to parse out, right? What are the specific elements of healthcare navigation and access that these families really needed? Um, so when we looked at the effects of insurance type and home language on the language outcomes of these children, right, we found that they had huge to very large effects, right, comparable to the social vulnerability index. And again, these effects, dwarfed those that we see with typical clinical factors and interventions. But what these studies showed was that insurance and home language were perhaps just proxies for deeper disparities and deeper issues relating to access to care, and specifically access to hearing specific healthcare. Um, so we have to add access into this model and try to understand that better. So how do we do that? Well, as it turns out, um, we had been measuring access or estimating access for many years. And so every, for many years, children undergoing cochlear implantation here in California, and this happens in other states as well, um, the cochlear implant team has to assess concerns on multiple different in multiple different spheres, concerns that the child would not have optimal outcomes with their cochlear implant. On the medical and audiologic sides, these are fairly straightforward things like cochlear nerve deficiency, right? If there's no cochlear nerve, then there's great concern that a child will have poor language outcomes. If they are older and they don't have any foundation of language, we also have greater concern. But all along, we had also been assessing concerns that are related to access to care, right? There was a subscale called educational support services that where the team assessed the degree to which early intervention support services were being met. There was a subscale called educational environment, which meant does the child have an educational environment that they can access? And there was importantly a subscale called family structure and support, right, where the cochlear implant team assessed the family's ability to take care of their child, right, and in very basic ways relating to housing, job status, social supports, and transportation. So, as a pilot study, again, another one of our students, Michelle Florentine, collected all of these access-specific ratings for our cochlear implant recipients, and found that these access measures associated very strongly with long-term language outcomes. And so we compiled these access measures into something called the Access Challenge Index. And in a larger study of 211 children, this was part of a different clinical trial that we are currently undergoing. We measured the Access Challenge Index in 211 deaf and hard of hearing children and looked at their language outcomes measured by the preschool language scales. Adjusted this for 18 different clinical and sociodemographic covariates. So we adjusted for their hearing level, for their income level, for all sorts of things like that. And we found that there was a very strong association between the access challenges and the language outcomes. And in fact, when we looked at all of the other sociodemographic covariables, right, the things that we normally think of as the basic social determinants of health, income, race, ethnicity, language, insurance, parental education, the Access Challenge Index was the only factor that remained statistically significant when accounting for all of these other variables. When we looked at the three specific subscales, educational support and educational environment, the family support subscale was by far most strongly associated. And so this probably comes as no surprise to all of you out there or any of us who takes care of these families, is that the key thing here is the family's ability to take care of their basic needs, and to have that first layer of being able to take care of their child. They have to be able to do that if they're going to be able to take care of their child's deaf and hard of hearing needs. And when we look at that Access Challenge Index compared to everything else on this graph, we find that it truly has a huge, huge effect. So these studies and others, I mean, we're certainly not the only ones doing this kind of work, is focusing in on access challenges as the primary sociodemographic factor that is driving these differences in language outcomes. And this is to a point that is comparable to, or if not greater than, all of the other clinical factors that we know. And, as I said before, this is probably no surprise to anybody, right? We know that we have the technology to support these children. We know that, a deaf baby undergoing cochlear implant by 6 to 9 months of age and receiving and having access to the CI, to the sound, to the therapists that are providing the support, like all of you, are able to develop spoken language comparable to their typically hearing peers. But it's that access that is the big problem. So how do we improve the access, right? And that gets us to the final phase, which is how can we design specific interventions to help with these specific access problems. So there's been a large body of research, right, including some of which that I've shown you, shows that deaf and hard of hearing children from vulnerable backgrounds struggle with accessing hearing screening, identification, and intervention, right? These are our 136 EDI guidelines. These are the three most important steps in getting a deaf and hard of hearing child to the intervention that they need. Um, and so what interventions can address these specific gaps? Well, there's three ways that our team is looking at this. One is postnatal hearing screening to improve identification. The second is using speech language teletherapy to provide better access to intervention to deaf and hard of hearing children and families. And care navigation to help these families understand how to navigate and access this care better. So I'll start with what we're doing with postnatal hearing screening. So newborn hearing screening is universal in the United States and in many other countries around the world. And it is a fantastic way of identifying deaf and hard of hearing children, right? Um, However, even though here in the United States, nearly 99% of children undergo newborn hearing screening, many of them are lost to follow-up, right, after newborn hearing screening. They may refer on the newborn hearing screen, but for a number of reasons, not get any follow-up care. In addition to that, there are a number of children that develop permanent hearing loss after the newborn period, and so they have postnatal onset of hearing loss. So when you project out to 6 years of age, the majority of children who are deaf and hard of hearing actually were not identified through newborn hearing screening. So we do have some safety nets in the United States to identify these children, right? But they only start at age 4, right? So pediatricians are recommended to start doing hearing screening at age 4. And in schools, they also do hearing screening, but that doesn't usually start until school entry at about age 5. Performing hearing screening in the preschool setting is a very important and potentially impactful way of identifying these children at a sooner time point. So we started a study. This is in collaboration with the San Francisco Department of Public Health here in San Francisco, where we began the process of trying to understand how best to perform preschool hearing screening, right? And unsurprisingly, right, so this was a study where we started using pure tone play audiometry and to look and see at what age kids were reliably able to do that, right? 2-year-olds are generally unable to be screened using traditional behavioral audiometry. And even a decent number of 3-year-olds are not able to be screened using play audiometry. So we tested to see whether otoacoustic emissions, right, which is a way of doing hearing screening without requiring a behavioral response, can be effective in backing that up, and as expected, it was, right. So having a second stage of otoacoustic emissions improved the overall ability to screen these children. But the problem with that is that it's not easy for preschools to deploy any kind of hearing screening, much less two forms of hearing screening with pure tones and otoacoustic emissions. So we've now started a prospective randomized controlled trial where we're aiming to screen 28,000 preschoolers to test to see whether otoacoustic emissions alone in this setting are as good as the two-stage pure tone and otoacoustic emission screening test. And very similar work to this has been done before, but we are, by doing a very large-scale project and doing it in very diverse preschools, everything from Head Start programs here in San Francisco to rural programs 6 hours away. The goal of this project is to establish a scalable standard for universal preschool hearing screening. And the intent here is that if we can get easy, low-cost hearing screening out to preschools across the country, that we'd be able to have a mechanism to identify late onset hearing loss or late identified hearing loss at a much earlier age than we're currently able to do. And this is a study that is currently ongoing and funded by the Patient-Centered Outcomes Research Institute. A second way in which has been proposed to help improve access to hearing care has been telemedicine or teletherapy, right? And specifically speech language teletherapy. I know AG Bell has done a lot of work in this space, and a number of you on the call are probably familiar with speech language teletherapy. And so we are in the process of conducting a randomized controlled trial to test to see whether providing access to speech language teletherapy is able to close the language outcome gaps between lower and higher income deaf and hard of hearing children. So for this study, we've enrolled 210 deaf and hard of hearing children. 140 of them are lower income as defined based on the poverty level here in the United States. And these 140 children, we've randomized them to receive either the usual care through their clinical programs and their educational supports versus their usual care plus access to specialized speech language teletherapy. We've also enrolled a cohort of 70 children from a higher income group who are receiving usual care. And we're measuring a large number of hearing health outcomes, everything from language to auditory function, vocabulary, speech, but also measures such as parental self-efficacy, satisfaction with the services that they're receiving, as well as the quality of life. And we're following these kids for 18 months to see whether providing access to teletherapy actually helps improve these outcomes. We have currently completed enrollment. We actually enrolled one more than intended. We'll complete the data collection by the end of this year. And what's significant about this study is that we, as you know, planned, have enrolled 67% of our subjects are from low-income households. A third of them are primarily Spanish speaking at home. Nearly half of them have significant challenges with access. And despite all of this, less than 5% of the families have withdrawn from the study. And this is really a testament to our research coordinators that have done a lot of work to engage these families in these research projects. One of the things that we've observed very early on is that children who were randomized to receive the access to the teletherapy, unfortunately, even though we've provided them with an iPad and a cell plan and access to a language congruent teletherapist, so the Spanish families had a Spanish teletherapist, they're still not able to fully utilize the teletherapy intervention. And I'm sure many of you have observed this as well. And so after this observation, one of our research coordinators, Michelle Wong, conducted an interview study. She talked with 15 parents who were randomized to the teletherapy intervention, half of which were Spanish speaking. And the utilization of the teletherapy was highly variable among these families. And we are currently analyzing this data. But she's identified a very large number of themes that are that these parents have articulated that have led them to either connect more or connect less with the teletherapy. And we're organizing this in terms of things like, what kinds of connections the teletherapists make, how the parents are involved, the degree that they've appreciated the parent coaching, other different kinds of barriers to accessing this intervention, even though it can be provided in their home. And we're hoping through this study to learn more about how we can go beyond just the basic technological access to teletherapy, to try to understand how to connect better with a diverse group of families, through speech language teletherapy. Finally, care navigation. So as all of you know, there are a number of different providers who are essential, to caring for a deaf and hard of hearing child. On the medical side, right, there are pediatricians, audiologists, otolaryngologists like myself, geneticists, speech language pathologists that are part of the medical team. And on the educational side, within the school, there are, obviously the child's classroom and classroom teacher and peers. In the early intervention space, there are early interventionists. And across the age spectrum, there are teachers of the deaf and speech language pathologists, all of which who are providing support, to the child. And in the middle of all of this, obviously, are the families. And the families need to coordinate and understand the needs and relative roles of all of these providers. And so it is likely that many of the access challenges are rooted in challenges specifically with complex care navigation. But to understand complex care navigation is complex, right? And so what we've done is we've undertaken a strategy to use something called human-centered design, to understand these access challenges better so that we can design better interventions. And this was work done by Nima Rashidi. He's currently a medical student here at UCSF. And the basic structure of human-centered design, is that there are several different steps, right? And the first and most important step is to empathize with the patients or the families that you are seeking to understand and support. And in this step, there's a structured way of doing interviews with these families as well as providers to understand the system better. And the second step after that is to take that information and to define the specific insights that they're providing you, to ideate, to come up with specific interventions that connect to those insights, and then finally to prototype and to test those interventions. And so he started off with a qualitative study, interviewing 12 deaf and hard of hearing providers, as well as 10 deaf and hard of hearing families, to understand more about this complex care navigation and the challenges that they faced. And the key insights that came out of this analysis are that families experience intrinsic barriers. So these are barriers that are intrinsic to the family themselves. They are feeling grief at the diagnosis of the hearing loss. There is instability in the home that prevents them from accessing care that is outside of the home. They don't understand the need of these different interventions or these different providers. There are extrinsic barriers, right? So these are barriers to accessing care that are outside of the home. Different providers can have trouble communicating with each other as well as with the family. As I mentioned before, the care is complex, right? There are so many different providers outside of the family that have to coordinate to provide the optimal care. And then finally, just straight up logistics, right? There can be long wait times for appointments. Families can have to travel a long way to get to their care centers. The families and the providers, however, also articulated a number of different opportunities to address these barriers, right? Um, Forming connections between parents can help with a lot of the intrinsic barriers of understanding and grief. Building relationships between these parents as well as within the between parents and providers and between providers can help overcome many of the communication and complexity barriers, and empowering the caregivers by increasing their understanding and increasing their engagement with the health system can empower them to advocate better for their children. So, from these insights, the folks that were interviewed for this can identify specific categories of interventions that can address these barriers. So being able to provide basic education on the child's needs and the roles of the different providers to the family in a very consistent and simple way can address many of the educational barriers and intrinsic barriers that families face. Being able to provide care coordination in multiple dimensions within the clinical system as well as across clinical and educational systems can address many of the extrinsic barriers. And cross-cutting across many of these insights is identifying the specific social needs that a family must overcome in order to be able to then address their child's hearing specific care. And obviously, there are a number of different interconnections between these insights and these interventions. When thinking about who can deliver these interventions, there is a specific kind of person that has been described in other systems called a patient navigator. And a similar kind of position with some slight differences is called a community health worker. But these patient navigators, their specific roles are to provide basic education to patients and families, to help coordinate specific kinds of care. And they can also take on roles to help identify social needs and connect families with specialized providers such as social workers as well as programs within their community. And so what we did is we piloted a patient navigator person, a person within the hearing health, within our hearing health clinic that performed these specific interventions. And what we found was really, truly remarkable. So we implemented this patient navigator about a year and a half ago, the specific patient navigator intervention. And we found that before the patient navigator intervention, the time it took between identification of hearing loss within our system and educational interventions. This is for children that were 0 to 3 years at hearing loss identification. And this was the time between when they were identified with hearing loss to when they had their IFSP sign. So this was the initiation of their early intervention services. That was 77 days before the patient navigator, and that dropped down to 34 days after the patient navigator was implemented. So this was an improvement of over a month of the time between identification and intervention just by having a patient navigator. And when we looked at the percentage of children that actually met their 6-month or EDI milestones for getting intervention in place, the patient navigator was able to improve the percentage of children that met that intervention milestone from 58% all the way up to 83%. So we are now in the phase of refining this patient navigator role to better serve the specific needs of our families, and we're hoping to scale this up to try to see whether this is scalable and whether it can be implemented in other systems. So, um, in summary, this is the translational research approach that we have taken to understand and address disparities in pediatric hearing healthcare. Right? We started with a clinical insight that we're all familiar with, right? That deaf and hard of hearing children are at risk for language delays, but that the outcomes are wildly different depending on the child. We've looked at a lot of data, both quantitative and qualitative, to try to understand the underlying mechanisms that lead to these differences, and found that hearing specific access challenges underlie a large amount of the disparities in these language outcomes. And by dialing in on exactly what these access challenges mean, right, that um, immigrant families are identified late because there's not a mechanism for hearing screening in early childhood. So let's have preschool hearing screening. Um, Families have a hard time showing up to in-person speech language therapy appointments, so let's see if teletherapy helps. All families have trouble navigating complex hearing healthcare systems, so let's see if a patient navigator can help. We hope that by further testing and refinement of these therapies, we can really address these fundamental challenges. And so, in summary, right, the interventions that we have right now, hearing devices to provide access to sound, speech language therapy and oral habilitation to support listening and spoken language development. We know how to make deaf and hard of hearing children thrive. We have all the tools available to us, and they can do it. At this point, the differences in outcomes are really primarily rooted in these families' ability to access that care that we are able to provide. And so, our greatest opportunity to improve outcomes is to pursue equity and to try to understand how to help our families access hearing healthcare better. And we are able, every one of us is able to do that right now with the families that we're taking care of. So thank you very, very much. If anyone has any questions, please feel free to reach out. And again, thank you to AG Bell. It has been really a pleasure to be part of this, and I'm excited to work with all of you in the future to help our families.
Thank you so much, Dr. Chan, for that amazing presentation. There's been a lot of questions. I'm not sure we'll have time to kind of get to them, but just to kind of summarize a little bit of the theme, some individuals were asking about specific slides. Dr. Chan has, shared his slides, so you can find those under your resources handouts, and then there you can access all of his slides and his amazing data. I know there was a lot of excitement once you got to the patient navigation, but there was also a lot of questions. We also at the University of Miami and the family support team that I direct are happy to also now have a patient navigator and have seen tremendous benefit in terms of access to care, particularly for our minority populations. But some individuals, maybe one question we can answer is, what is the background of a patient navigator? And, is it specifically, do they have to be from a certain role? And so I don't know if you can have a few minutes to address that.
Yeah, that is a great question. So in our patient navigators have actually, we have a hybrid role. They are research coordinators that double as patient navigators. All of these individuals are basically recent college graduates that don't have any specific background in clinical care or deaf and hard of hearing care. But they have been onboarded with these specific roles, so they don't have to have any prior background or knowledge. However, other programs have used community health workers in this similar role. And community health workers are often actually people who have lived experience in this field, right? So they're often parents of deaf and hard of hearing children who want to sort of give back to the program. And they have this unique ability to directly connect with families and empathize with them. So, you know, they can really be anybody. Patient navigators can be anybody as long as they care about these kids and their families.
Absolutely. And I know we're really down to the wire, but Dr. Chan's team and SLPs, I saw them very active in the chat. So feel free to reach out to them or to Dr. Chan if you want more information. But, unfortunately, the time has come where the session is pretty much over. And we want to thank Dr. Chan for an amazing keynote presentation. Remember to please complete the session feedback and CEU learning assessment form for this session if you wish to receive credit for professional and continuing education. And again, thank you so much for an amazing talk today.
Awesome. Thanks so much, Yvette.